Welcome to Journey to Joy Live, a podcast to promote wellness, resilience, and inspire joy. Be empowered to balance your mental, physical, financial, aspirational, and social health while providing mental health awareness and breaking down the stigma of mental illness in the Black community. I'm your host, Dr. If Joy, and I'm here to help you transform life's challenges into opportunities for joy. Let's begin the journey together. Hello, everyone. We are in episode 143, Her Power, Her Joy, Her Longevity, Rewriting Menopause. And my special guest is no stranger to Journey to Joy Live, Dr. Renée Allen. She's an OB-GYN physician. This is, your fourth time?
It's third, because I think the very first one is like your 91st episode.
And then you were like 100. You came on quickly for the
100.
Yeah,
you
okay, so this is third. Okay.
Ah,
Premonition for the fourth then.
yes,
Well,
yes.
thank you for coming back. Menopause, perimenopause, that's the hot topic. That's what we're all talking about. I mean, not that menopause has been something that we haven't been talking about, but it just seems like it's what we're all in, especially me and my friends, because I'm in that age now. And I was shocked at when you were saying around 41, even as low as 37 at the first podcast you came on episode, you were just like, yeah, you can start seeing symptoms. I'm like, no, I'm not ready.
Yep, yep. Yeah, exactly it. So basically, menopause is not a phase. It's actually a biological inflection point. It's
Yeah.
a whole system accelerant for aging in the brain and the heart, metabolism and the mood, and it starts silently years before your last menstrual period. So, yeah,
Mhm.
perimenopause begins about 8 to 10 years before that final menstrual cycle, and ovarian reserve is already declining during that time.
Mm.
Get labeled as stress or anxiety a lot of times, and most women are told to wait and see, but the biology is already
Okay.
posted in their late 30s.
Yeah. Oh, wow. Makes sense. So you said menopause isn't just a phase, it's an act of an accelerant for aging. So can we explain what you mean by ovarian aging or what is meant by ovarian aging being a root driver of a woman's health span?
Right, it's an inflection point. I wish that I could show you a graph. So, like, estrogen or estradiol, that's the most powerful form of estrogen that our body produces. It protects women, cardiovascularly all through their life especially in their reproductive years. And it's the
Mhm.
years and it makes sense. There's estradiol receptors all over our body in every single organ system. And what you need to understand about your body is that your body's not going to expend energy to do things. Um, what if it's functioning normally
Mhm.
unless it's something that's gonna help you, okay? Many times, your body this is my opinion, the 2 main imperatives of your body is 2 things: keep you alive, and if you're a woman, for
Yeah.
you and also for men, but more so for women, is for you to reproduce, okay? For you to
Yeah.
procreate. And
Mhm.
so it actually those 2 things, your body throughout your life will do certain functions in order to put you in the best chance for both those things. So, like, for example, if you get into a car accident, your body, in an effort to keep you alive, may cut off certain like blood flow to certain organ systems and leave only the essential ones. And you're not fully functioning, but you're still alive, right? Like, so it does that. With regards to reproduction, um, the estradiol levels, once you reach puberty and your sex hormone levels are starting to increase, this
Yeah.
is my opinion that it actually allows you to become the most strong in your life to do the hardest work. I think I've talked
It
to you
makes
about,
sense.
yeah, the hardest work that a woman can do, which is to procreate, to actually
Mhm.
life, right? Everything about it is set up actually for failure. I'm telling you, the mere fact that we're here, it
Mhm.
is like a miracle. So, and
Right.
even the risk that it takes on the woman who is undergoing this to bring forth life, it
Mhm.
is very dangerous period in a woman's life, especially right after she delivers with the hormonal shift changes,
Yeah.
mood shift changes. If you have, like, for example, if you have like a history of heart disease, you're going to most likely find yourself being closely monitored those first 24 to 48 hours after delivery, because we know that your body's undergoing such rapid changes. And if you have heart disease, that could be the time where you may get heart failure or some
Yeah.
cardiac event can occur. So
Yeah. Got the preeclampsia, not to mention if you're over the age of 35, you're
yeah,
elderly.
right. So I remember, I don't do hospital medicine anymore, but, I remember when I was doing it, if you had a certain diagnosis, let's just say that you came in, all right, this diagnosis is over the top, but it still proves the point. Let's say that you have pulmonary hypertension, which is
Mhm.
elevated pressures within the vasculature of your lungs, right? Your respiratory system. Um, for those women, it's actually a contraindication to be pregnant. That's the first thing. But let's just say that
Wow.
yeah,
Yeah.
because of that very reason, because we know how what the stress that undertaking reproduction, pregnancy, and delivery and surviving that, what it can do on your body, right? So for those women who may have that diagnosis, she's going to end up in the ICU directly after she delivers, because we need like really close monitoring, because we understand that. So estradiol, that hormone, it is set up in your body in order to make you the strongest that you can be, in order to undertake the hardest work that a woman's body can undertake. When your estradiol levels start to decrease, then it starts to reveal everything that the estradiol was doing. And the main thing with women
Yes, that
is
makes so
that,
much sense.
yeah, the main thing with women is that the estradiol was really protecting your heart. And that inflection point I told you is that once a woman crosses over into the menopause period and her estradiols plummet, she starts to now have the same risk of cardiovascular disease as men. And then at a certain point, she can surpass men. So all throughout her life, estradiol was protecting her heart. Menopause, game over. That's the inflection point. Now you're at risk, and even more risk, of developing heart disease than men. And what women don't realize is that cardiovascular disease is the number one killer for women. It's not breast cancer. That's what a lot of women don't understand. So most women, the ovarian aging, it drives not just hot flashes, but also, this is your area of expertise, cognitive decline and depression. And it also drives cardiovascular risk and metabolic disease. So when the ovaries go, every organ system downstream is affected, including and specifically the brain. So I think, this is a good bridge, because I remember in one of the episodes, the earlier episodes you and I were
Yeah.
on, you were talking about a patient that you had that stopped her HRT because she thought it was.
Yes.
Remember that? I'm
Yeah, I do.
yeah, I'm looping back to that because
I
it
still
didn't.
see her.
Yeah, it didn't. It's actually the declining estrogen that her body was just naturally under.
That's causing depression, not necessarily her
Cause
hormone
yeah,
replacement causing depression. Well, that's true because looking back, and I'm glad we're circling back to that, I still see that patient, and I was just like, "Huh, maybe we're in the clear. Maybe it really was your HRT."
no, she
But they
abandoned.
she ended up having a reoccurrence of the depression, so it's not like
Yeah,
her
she
being off of
abandoned.
her. Yeah.
Yeah, she abandoned the very thing that was protecting her mood. So this
Mm.
misattribution, to the estradiol that it was causing the depression is happening to thousands of women. And tonight,
Yeah.
we correct the record. The clinical truth is that restoring hormones reduces depression risk by nearly half in the randomized controlled trial data. And your patient's worsening of mood after stopping
Mhm.
T, it was withdrawal from protection, not proof that the therapy was harmful. And a physician who understands that mechanism
Yeah.
changes the game for everybody.
That's
So
really good. I love how you started out from puberty because we need to really hear like what is happening when that happens when estradiol is increased and what it's doing over the lifespan. And then now we're removing it. So it's like all these things are happening.
yeah.
That's really well explained. Oh my goodness.
Yeah. And so, basically what we undertake at this point is now we need to understand that there is cutting edge therapies that can actually
Yeah.
delay this. And that's kind of the what I wanted us to get
Delay.
into. Yeah. I wanted us to get into that.
Yeah. Yeah. Well, let's jump right in because I was gonna ask you, 'cause I know you mentioned to me about, rapamycin, peptides. There's also that, I think it's mTOR, targeted
Yes,
strategies for slowing ovarian
yeah,
ages. I mean,
yeah,
what's
let's talk about
scientifically
that.
grounded?
Yeah,
What's just still theoretical?
yeah, let's talk about how we can slow the aging of the ovary itself, and what's
Mhm.
out there, what does it mean for women's health span, for their mood and longevity. So, basically, real quick, so we are born at birth, we have about 1 to 2 million follicles at birth, okay? And then at
Wow.
puberty, it decreases. Our eggs, unlike men, it's different.
Mhm.
Men produce sperm for life, okay? Women are
Yeah,
born with every egg they will ever have, and then they lose them constantly from that point on. From that point
exactly.
on, okay? So the
Yeah.
rate of follicular loss doubles by the age of 40. It's not gradual, it actually accelerates. So we're born with about 1 to 2 million, and then by the time with puberty, we're at about 300,000 at puberty, okay? By the time we're about 38 to 40 years old, we're at about 25 to 30,000 eggs, and then
Which is wild that we still have that many.
yeah, but we started with about 2 million, okay?
Right.
Rapid decline, and then at menopause, by the time we're at menopause, you probably have about 1,000 eggs. So
Mm, mm, mm.
it's gradual, and once you hit 40, it just accelerates. So AMH, have you ever heard of AMH? It's
AMH, what's it stand for?
anti-Mullerian hormone.
Oh, yeah, I know AMH.
It's a biological clock that you can actually measure. It's a test marker, and women who have gone through, fertility treatments like me, that's a whole other
Uh-huh.
story you need to bring me on for, 'cause I've
Oh,
got
yeah,
stories.
fertility, we
I
can definitely
got
talk about
stories
that.
for you, girl. I went through 16 cycles in order to have my
Oh,
little monster
oh,
4-year-old son that I have here, but anyways, that's a whole
oh,
other story. But,
I can't wait. Gotta get
AMH is
scheduled.
the biological clock. It
Yeah,
actually measures, most women haven't had this test unless you're at fertility, and every woman over
yeah.
35 should know what her AMH level is. It reflects remaining reserve of your ovarian follicles,
Mm,
and it
mm,
trajectory of decline. And so as your ovarian follicles go, so does your estradiol. And that means which is remember I said in the beginning, the estradiol level affects your brain,
yeah.
cardiac, bone,
Bone.
metabolism, every part of your organ.
Yeah,
So as your follicles are declining, your estradiol is declining, so it impacts your body. So losing it is a whole system event. It's not just a reproductive one. And that is what I think women need to understand. And so what's the science showing? It's really
yeah,
it's really exciting. We have
good.
rapamycin, okay,
Uh-huh.
that's an FDA approved immunosuppressant,
Mhm.
it's not like an anti-cancer medication. It's not,
Okay.
cancer medication. It more comes from,
We don't want
a
that.
bacteria, okay, so it's not a chemotherapy. Let's just put it that
Okay.
way. It comes from a bacteria. What it does, it inhibits mTOR. mTOR is the signaling pathway that accelerates whether or not it kind of tells your cells, are you going to divide? Are you going to grow? Are you going to stay kind of like silent, or are you going to, clean up and kind of like go away? It kind of
Okay.
directs your cells as to what your cells are going to do. So mTOR in this situation, it accelerates follicular burnout. So there is in Colombia,
Mm.
there's a trial that occurred. They did a mini trial, little small trial, I think about
The country of Colombia or Colombia?
university,
Oh,
New York, yeah.
'cause my husband's from Colombia, so that's where I go
Yeah,
straight
no,
to.
no, you didn't hear me say university, but Columbia University
Yeah, I
in New York,
missed it.
they did a small little mini, trial of 50 women, menopausal women, and they looked to see if rapamycin could slow down ovarian aging, and it showed that it
Yeah.
did, to the point where they now have a larger study called the Vibrant study is going on, and it's specifically looking
Interesting.
how to slow ovarian aging and extend reproductive health span. So
I was
basically,
gonna say, what would that look like? So if you're expanding reproductive health span, you can continue to have kids.
yes, that means that you can delay menopause. And, for some women that be like, oh, I don't want to delay menopause. But if you're looking at it from what the hormone decline does to your body and how it increases your risk over time of
Yeah.
chronic diseases of aging, then this is a significant breakthrough. Okay. What you guys have to understand is we living past menopause, this is a new event in human evolution. We used to die off. Okay. So
Mhm.
we're now seeing what the effects of 30, 40 years past menopause, which means past those hormones that were protecting us all our lives as women, what that means. Like, what does that mean? What is the outcome of that? We also had
Mhm.
a real nice glimpse with the WHI study. That whole fiasco back when I was training in Emory as a resident back in the early 2000s when it came out, and it was the data was completely wrong. It was based only on synthetic medications, and even to this day,
Yeah.
they're trying to extrapolate the the findings for the synthetic meds to the bioidentical hormones that we have now, 20
You
something
talked a
years
lot
later.
about that on the last time you were here.
Yeah, you can't. But we saw that because that came out and scared everybody. I remember I was in
Mhm.
they used to have, like, the good old boys, because Emory's Southern, so, they had the good old boys, and they had their menopause clinics, and they were doing their thing. They had their partnerships with the compounding pharmacies, and they were telling them to do all these custom-made formulas for their women in the menopause, clinic, and they were teaching residents all of these secrets and, protocols that were handed down to them, because this is not
Ah.
anything new. This is not anything new. Like, back in
Yeah.
the 20s, women were taking women of affluence who had money. They were, taking ground up cow ovaries, and it was helping them. What they found that was in
No
it was
way.
testosterone. Yes, my dear, menopause treatment is not new. All right? So,
Right, now the trim is not new, but cow
yes,
ovaries.
doing cow ovaries, and they were taking women you had to have money in order to afford that. I'm talking about almost 100 years ago. But
Were they
women,
eating it or injecting it?
yeah, just they were having it as they were eating it. So, it was
Oh!
ground up, they kind of were able to put it like a pill, like it was medicine. And
Okay, like a pill,
yeah, it wasn't
like
yeah,
M&Ms.
pill. It was yeah, like a pill, but they were eating it. It was their form of therapy, and they specifically honed in on the cow ovary. And we tested that, and what it was that they were really getting is testosterone. But the women were it was helping them. It was helping them. So menopause therapy is not new. So,
Yeah.
these secrets that have been passed down, there's
Yeah.
different protocols, women were helped. They stopped teaching it. At least they stopped teaching what they were doing in their menopause clinic, and then we started on this minimum dose for the shortest period of time because they were talking about synthetic hormones.
Yeah, which
And of
isn't good
course
for you.
they're not good for you.
Yeah.
And so they stopped teaching us. A lot of women came off of menopause hormonal therapy because a lot of physicians were scared too with the results. And now we're seeing 20 something years later what the outcome is. There's a high incidence of osteoporosis, Alzheimer's disease,
Yeah.
heart failure, hip replacements amongst women because of that very WHI study. So
Mm-mm-mm.
living past menopause, that's a recent change in human evolution. So now, do you really wanna live 30, 40 years without these hormones? Because
Without
what
all
that
that.
means is it's the difference sometimes between being able to open a jar. Like, that's what aging comes down to. People don't understand that when you age, some people can't even open jars anymore. It's because
Yeah.
your
Does
quality of
it
life.
change things, like, if you are a person who maintains a high level of fitness or if you take creatine and you're a little bit more stronger or high protein, does that
It
change
does.
anything?
It does. It will help you to improve different markers that your body needs to do different functions, but
Yeah.
nothing is going to ever replace hormones. Hormones are life.
Mm-mm-mm.
Hormones magic.
Wow. So
Period.
rapamycin slows the process, kinda like how the medications for Alzheimer's, it slows the process, but it doesn't
So let me
prevent it, obviously.
It does not. So I'll give you more of an example that's more concrete so you guys can understand. Like,
Mhm.
in the study, it actually says that, let's just say that you per day, when you're in that rapid acceleration period after 40, when you're losing the eggs, say that you lose 50 eggs a day. Rapamycin will let it slow down where it's like only 15 eggs a day. So it's a
Okay.
significant reduction, but it doesn't stop it altogether.
And
Okay.
that's really important because with the high achieving woman who has focused on her career all this time, she 42, just now getting married and still would like to have
That
kids.
is
So
a
this is
whole
important.
other topic that you and I need to delve into. I've always said that at one point in my life, I do want to start to go back to medical schools and residencies and lecture and tell them, listen, girls, don't believe the hype that you can do it all because you can't. Okay. Like,
Mhm.
there is something that you're going to give up, and it may be something that you never thought that you would you would have to make that kind of decision. And
Yeah.
so you need to start planning, because when you go down this path of I'm just of our journey, okay? Because you and I know what it took for us to become MDs and to be up in this medicine, right? It took a lot. It took
Yeah.
more than
Sacrifice.
half my life in order to do it. Like, all that I have, like, 3 degrees, right? And that doesn't even include
It's
getting
awesome.
yeah, it took half. Alright, so you're on this journey, and it's like you're tunnel vision, and you understand. You remember residency and all that? You're gonna delay if you wanna
Yeah.
if you wanna be a mom, I'm gonna tell these go and freeze your eggs.
I was
Do
gonna ask you about that because people talk about that too.
eggs,
Because I know I
not
certainly
me.
delayed dating and all that,
So
but there were classmates who were having their kids in med school. They were like
and they were the
9.
smart ones. I'm telling you honestly, they were the smart ones. So if you are set up where you have a partner, whatever, and you're in med school,
If you have a
have
partner.
your babies. Don't listen to any of your fellow residents,
No,
your
wait.
residency director telling you to wait, because they will,
Oh my
because they
goodness.
want you to be in the work pool so that you're on call
Successful.
or whatever. You do what is best for you, because you cannot have it all. That's why I'm telling you, you need to come, and we need to come back so I can tell you about those 16 IVF cycles that
Oh,
in order to
yes.
have
Put
my
you on the
one
books
son,
now.
because I believe the hype that I could have it all, and you can't. So you have to make certain decisions as a woman in your life, especially if you wanna be a professional woman where there's a certain track where it's gonna dedicate
Yeah.
a number of your lives. You need to be smart about it, and your fertility is not gonna wait for you.
Yeah, and we both have young children. Is that your only child you mentioned?
Oh, girl, I could
Well, there you
never
go.
I went through 4 years back to back of injecting myself every day. I'm not joking, and I'm not exaggerating. 4 years.
Yeah.
So, no,
Yeah.
never do that again.
That's stressful. Yeah, we can definitely talk about the mental load of that, but
Yeah.
since you mentioned the freezing of the eggs, so obviously that's safe, right? Is
Yeah,
there any
I
risk
mean,
to
well,
that for the fetus?
so in order for you to freeze your eggs, your reproductive endocrinologist and an infertility specialist has to put you on
Mhm.
a certain cycle so that you are producing more eggs than you normally would per month. So there
Yeah.
is hormones involved with that. They are bioidentical, meaning they're the same type of hormones that
Mhm.
you are making in your body. So it's not like they're synthetic, but yes, that is involved. And so you do have to increase your hormone levels significantly in order to freeze your eggs, because you want them to only do it one time, right? It's going to be one outpatient surgery, so you want them to get as many as possible. And we really only l- every month maybe ovulate 1 or 2 eggs. You know,
Yeah, right,
enough to
exactly.
but we want a lot. When you're freezing your eggs, you want them to
Yeah,
get once, you want them to get a lot. So you have to give them a lot of hormones.
increase yeah, okay.
Yeah.
Makes
But
sense.
all right, so rapamycin, really
Yeah,
exciting,
that's
okay?
it.
There's other peptides too that we can use,
Mhm,
help, not necessarily slow down ovarian aging, but we can layer it in to help with other things. Like, for example, and some of these that I'm gonna be bringing up are, FDA approved, and we're using them as off label, okay? Like, so for example, there is a medication called tesamorelin. That
mm.
was recently FDA approved for HIV associated, visceral lipid
Oh.
dystrophy. So what that means
Mm.
in layman's terms is
Mhm.
it's specifically for people
But
who
I need to lay my terms on that one.
specifically for the people who so in certain subset of HIV positive patients, the way that the disease manifests within them is that they end up putting on a lot of fat, and
Mm.
specifically in the visceral fat, which is surrounding your internal organs, can be
Yeah,
your liver, your pancreas, if you've heard of fatty liver term,
mhm,
that is considered visceral fat. And so for whatever reason, these HIV, it triggers something where that's how one of the ways that the disease is manifesting within that individual. And this medication, this peptide, tesamorelin, is specific in that it's identical fat phenotype. Um,
mhm.
well, let me just say the reason why it's really promising for menopause is that visceral fat, as your estradiol levels go down, your visceral
Yeah.
fat level goes up.
So
And so it's
yeah.
the same phenotype that we're looking like in menopause, where you have more fat internally surrounding your organs, and that
Mhm.
causes aberrant hormone release. So hormones that don't want released will be produced and released, and chronic inflammation that can increase your risk factor of everything. Okay. So the mechanism of testosterone is that it stimulates the growth, GHRH, growth
Okay.
releasing hormone receptor, and then increases growth hormone and IGF-1. Okay, I'm taking you way back to, med
I
school.
remember.
So then once it increases growth hormone and IGF-1, it
Uh-huh.
causes the visceral fat to break down, and then it preserves your lean muscle mass,
Yeah, that makes
and then it
sense.
restores the growth hormone axis restoration. Because a lot of times you have, an HPO axis dysregulation that occurs.
Mhm.
And so this ends up reducing your inflammatory markers significantly, and then there is, like, within vessels, the carotid intima media thickness, it actually makes it go down. So the vessels become more pliant, and the decrease in inflammation, it
Yeah.
resu re resulting in decrease in visceral fat. It also has a neurotropic effect, so it helps with brain function as well too.
Well, that's good.
Right, so this bridges metabolic and cognitive decline in one agent, Pasmarelin, okay?
Gotcha.
And so I use that. I will use that, at any point in a woman's journey if she's just for weight loss or BHRT,
Okay,
if you
weight
have
loss makes sense.
significant amount of visceral fat. And how I find out is that my patients end up getting either full body DEXA scans, where I can see what their lean body tissue is versus the
Mhm.
amount of fat that is internal within their abdomen, or even sub-Q. Or some of my patients get at home in body
Mhm.
scans where they can see it. But either way, I can measure what we're looking at, what is the percentage of fat to lean body tissue,
That's
and then
awesome.
I can give you tesamorelin off-label use, and we can significantly measure it going down over time.
And can you also be on it also with the rapamycin as well? Because it seems like they do completely different things, completely
Yes,
different mechanism of
I
action,
take rapamycin. Now
completely
that
different indications.
Yes, I didn't tell you, and I take rapamycin every week. It's a weekly dose, 5 milligrams.
Okay.
Yes, you can, because the rapamycin is gonna work on a completely different mechanism. It's working
So
on
what have you noticed since being on it? How long have you been on it?
I've been on it, I think I started, like, a 3-month course, and I might have 5 pills left. It's once a week. A little bit more energy. Um,
Okay.
my I'm still menstruating. I'm perimenopausal, so, I think the first couple of weeks when I took it, my period came a little bit quicker than it was supposed to, so that was interesting. I
You're
thought
like,
that Yeah,
"Uh-oh."
I thought not necessarily, I just felt like, to me, I felt like it was taking some sort of effect, and I was
Okay.
looking forward to see what would happen. My period that came that day was or that month wasn't painful. I normally have really painful periods, so it was a
Mm.
period. And I'm halfway through the therapy, so bring me back for me to tell you what ended up.
Exactly, we're talking about all
It
that.
changes my test markers, because every 3 months I take repeat follow-up labs, because 'cause I'm being optimized myself. I'm a patient, and, I'm under care to get BHRT.
Yeah, of
So,
course.
yeah,
Take care of
so
your
bring
own
me
health. But
back.
it's
Yeah.
good to hear that you actually take the things that you are
Oh,
promoting.
oh, yes. I don't practice conventional medicine anymore. Honestly, if I look at how I
I
practice
know.
trained, completely different. Everything that I recommend, I do it myself, and either myself or my husband.
Yeah.
I treat men too, and he's my patient. Um,
Oh,
so
that's
yeah,
dope.
and that's what in this longevity regenerative medicine, because that is the type of medicine I practice. The foundation is hormone restoration, because that's the foundation. But then I add on other things that are longevity and regenerative medicine focused, like the peptides or bioregulators or the rapamycin. But this is something where in this space, doctors who decide to venture out, you are iconoclastic. You are standing out, and you're taking a stand, and you're a little bit of a target. We don't have a lot of research, because the research, our randomized controlled trials, are run by the
That's the
pharmaceutical companies.
thing. Yeah.
And a lot of times, what if they do these studies on these peptides, it's because they want to take it themselves so that they can make a lot of money off,
Mhm. Well,
right?
people are looking for alternatives these days. They're looking for off-label.
So
It's
doctors tend to
working.
try it out on themselves when they're in this space, and
Mhm.
then they'll venture out, to select patients very carefully. We don't jump really quickly into it. We need to see, a lot of anecdotal data first, especially if we don't have studies to kind of back it up. But yeah, it's not anything new. That's what we do in this space. Is
Yeah, for sure.
yeah,
Yeah, and that's everywhere. Of course, we use a lot of off-label medications in the field of psychiatry as well.
yeah, yeah. So, I mean, I think it's really exciting.
It
The
is.
brain. One thing, and I think this is because this is your area of expertise with regards to mental health and the brain.
Yeah,
Brain runs on estrogen. It is when ovarian function
yeah.
declines, brain glucose metabolism significantly declines with it, about 30%. And it's measurable on a PET scan. And this begins years before that last menstrual cycle, years before. So,
Mm.
and, to be really specific, it regulates mitochondrial bioenergetics in the brain.
Mhm.
And so that loss of ovarian estrogen is a loss of brain fuel. That's why women are getting like the brain fog,
Brain
or
fog!
retrieval loss, the concentration failures, and perimenopause.
I
A
hear
lot
that
of
all the
that
time. I have a patient in her 70s that talks about that, attention
is
issues, brain fog, just like
it is energy
yeah,
deficit at the cellular level. It is a
yeah,
deficit of energy of your brain cell. So of course you're gonna manifest it and express it, word loss, retrieval. So there is a scientific reason for what women are
for
experiencing. Do not
sure.
settle for it's just aging. It is treatable, reversible. You just restore hormones. That's all you need to do. It reduces depression. Okay, there's this randomized controlled trial where they gave estradiol and micronized progesterone, and it cut depression by rates from 32% to 17%.
Oh my goodness. Now that's a lot when it comes to depression. So, and you were saying on the previous episode that anxiety is the first sign of perimenopause, and of course you can get depression when you're losing these hormones. So that's
Yeah,
important to know.
yeah,
Don't just see your psychiatrist, see your OB-GYN too.
yeah.
There might be something else going
I
on.
mean, you know this, but I'm sure your audience doesn't know this, that Alzheimer's, 2/3 of Alzheimer patients are women.
Mm, mm,
Menopause is
mm, mm.
coincident with early
I don't even
Alzheimer's
know if I realized that.
brain changes. 2/3, it's majority women. There's a critical 5-year window at menopause
Wow.
onset where estrogen, like if you give it the estradiol at that point, you're gonna have a
Yeah.
significant neuroprotective effect. It's time dependent. We actually have studies that show that, and that if you start estradiol later than
Oh
that
wow.
5-year
Ooh,
window,
that's
it
important. So
doesn't
we all should just
trigger.
get on it, or do we have to wait?
Well, look, you just need to find a hormone
What's
specialist
that
who's going
window?
to, um well,
Yeah.
the window I was talking about with regards to, protection for Alzheimer's
Yeah, yeah.
is within 5 years of menopause onset, and menopause is
Okay.
12
That's a
months.
good window. It's a
So,
big
yeah,
window.
5 years. Then if you are able to start it within that window, it has a significant neuroprotective effect, that's time dependent. If you go outside of the window, so if you start
Yeah.
it, well, like 10 years out, it doesn't confer the same protection. There is protection, but it's not as significant. Does that make sense?
Yeah, yeah, for sure. So let
So
me ask this. If we truly have these tools that might actually slow ovarian aging, what are the ethical considerations? Who gets access?
well,
How far should we go in delaying menopause?
So this is cutting edge. So these studies, that Vibrant study I told you about with rapamycin,
Mhm,
it's underway. It's not been completed. They still are
mhm.
gathering data. We know about it because we know that they wrapped up the mini study and that they were so excited about it that they ended up getting the larger study. But certain people in this space, they took that and they are starting to treat with it. So I am willing to treat a patient with these off-label agents, um,
Yeah,
as long as they are the right, appropriate candidate. So you just have to go to someone, speak with them, give them their history, let them determine if this is right for you. Even hormone therapy, because I'm not saying that this is the panacea for everybody, because there's certain people out there that they have significant risks they're coming in with, like genetically or what have you,
yeah,
that not all the hormone therapy may be appropriate or a certain delivery form because hormone optimization is not
yeah.
just the hormone, it's actually like the route of delivery. Are you going to give it injection form? You're going to give it transdermally through like the skin? Are you
Case
going to
by
give it
case.
orally? That there's different risks associated with the different routes, and then the frequency and the timing. So it's all interrelated. So I
Yeah.
wouldn't say that everyone needs to be on hormone. I would say that you need to talk to a hormone specialist, let them really dig into your history, get testing, because there are like a lot of people saying that you don't need to test. Yes, because the hormones affect so many different things. You need to test your inflammatory markers, your lipid
Yeah.
panel, your thyroid, all of that. Get tested. Let them dig deep to see
Yeah, it's case
what it
by case. It really depends on who you are, your body, but it doesn't hurt to go in to see somebody. So let's say a woman walks into your office. She's 40, she's exhausted, she's anxious. She's just like, I'm just not like myself.
yeah.
How do you approach the evaluation and design a plan for her?
Um, So if she's not a patient yet, then coming into my world, she would get like an initial visit. I call it the ground zero consult because I want to see where she's at, where her mind's at, what her goals are, what does she want, what's going on with her, and what does she ultimately want to achieve.
Mhm.
She and I talk about that. She understands a little bit more about the practice, the things that I can offer, because it's not a conventional practice. It's different, right? And then we kind of determine if it makes sense to partner together. So that's the first step, someone coming in. Then let's just say that we decided they're going to work together. So she's on the side. She's going to get a very comprehensive lab panel done, my own. And I'm changing it all the time as I'm learning because I'm always learning. Every other month, I'm going to different, 3-day workshops to keep learning and learning, right? So she'll get a comprehensive panel. And then about 2 weeks after that, she and I will meet for a 2-hour visit. And we are going to go through that panel in detail. She's going to come out
Nice.
understanding exactly where she's at, exactly what the literature and the medicine says,
Mhm.
and what we can achieve, like what we can prove, like what we can improve, okay? Then we'll come up with a plan that's specific to her based on her lab values of what we want to improve. And so every plan is different. Um,
Yeah.
may layer in peptides right away. I may not. She may come in with a lot of gut health issues, and I may need
Mhm.
get that all prepared either before or concurrently. Everyone is a unique, beautiful butterfly in my practice, and she gets a lot of hands-on care. So my practice operates outside of insurance. Like, when's the last time you think you can do a 2-hour visit with a patient in insurance?
Mm-mm. No, and be able to bill for it. And then your practice is at Renée Allen, MD, correct?
And the type of therapies that I offer are considered experimental, so it wouldn't be approved through insurance anyway. But if it is attractive to a certain type of patient who is very health span focused and is
Yeah.
out there in the wellness space and wants that longevity regenerative medicine, that is the practice that I have. I'm for you.
Yes, that is so awesome, and I just keep saying every time you come on, like, who would not want to go to your practice? It sounds like you're offering all the good stuff, all the innovative, techniques, and that is pretty awesome. So reneeallenmd.com. This has been a great conversation. Yes, you are coming back for the 4th. I already made a
Oh,
premonition
you know
thinking
you're
this
my
was the 4th.
favorite podcaster. You know that.
Well, thank you. And I had to have you for March because this is the end of Women's History
Women,
Month, and been talking about all things women.
right.
So, our joy has to do with our hormones and our body changes and all these things. So it was really good having you and
Thank
talking
you.
with you.
Yeah, ladies, like, just don't accept that it's aging. It's not. I mean, it is aging, but you don't have to feel the way that you do, and you can actually feel like you did in your late 20s. I
Do
take my
something about
patients
it.
back to feeling that way,
Yes.
you know? Yeah.
That's a good closure. She takes people back to feeling like they're in their 20s.
Yes.
Go to her website
Yeah.
right now.
Thank you. I love spending time with you. I love it.
Me too. Thank you so much, and I will see you next time.
Alright.
Bye-bye.
This has been an Enjoy Life production. If you're in a crisis, don't hesitate. Call, text, or chat 988 for immediate support. Please note, this podcast is for informational purposes only and is not a substitute for professional treatment. If you're looking for therapy or medication management through Enjoy Life, visit www.drenjoylife.com to request a consultation. I'm licensed in 13 states. I accept Aetna in Georgia, Florida, and Virginia. Be sure to grab your copy of the Enjoy Note to help you on your wellness journey. Also, check out Inspire Joy for the wife mom boss to help you balance it all without losing yourself. Better yet, get the full Joy bundle for just $45. Remember, Journey to Joy Live is every Thursday at 7 p.m. Thank you for joining me, and until next time, may you continue to transform stress into joy.
Girl,